What we've done is we've redesigned the entire innovation pathway and developed a more clinician-focused pathway that reduces the barrier to entry.
Welcome to the LearnSkin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
Hey, Hadar, I'm feeling a little innovative. What about you?
I know, we keep being innovative all the time, but there's a big difference between having a great idea, which are a dime a dozen, as you know, as opposed to really translating, getting it done, so to speak. And I don't know about you, but I know that I'm talking to residents every day and medical students, and they all say, oh, it'll be great if we can solve this problem, that problem. But then it never really kind of ends up happening, don't you think?
Yeah, well, the thing is, you go to medical school and you don't really learn to think outside the box because you're learning what the box looks like, right? And so
that's right.
But we need people that think outside the box, and we've got an outside the box thinker. And I might say that I met her interviewing during our residency applications for dermatology at one of our interviews. And it's amazing how we've kept in touch, over the years, not like closely in touch, but we have a level of familiarity. So we have Dr. Lilit Garibyan, who is an assistant professor of dermatology at Harvard Medical School. She is a really innovative physician. She's a physician scientist at the Wellman Center for Photomedicine at Mass General. And she's really focused in on thinking about innovation. So she's the co-founder and the director of the Magic Wand Initiative, which is really looking at promoting and empowering clinician-led research and innovation by teaching clinicians the whole process of innovation. I can't think of anyone better than to have you on this podcast, Lilit. Welcome.
Oh, thank you so much, Raja and Hadar. It's a pleasure to be here.
Hey, welcome, Lilit. And I think it's, as I described in this opening, I've always thought it's so important to find some tool or some way to kind of capture all these ideas because, gosh, in clinic, if we were to go through all clinics in the US right now, just in dermatology, and I bet you we can identify a million different problems that require practical solutions, but they all kind of die in that moment when they arise and then kind of slowly phase away from the brilliant minds of all the dermatologists who are looking at them. And I think that's the kind of problem you started with, right? We came up with this magic wand concept. Can you tell us what it is?
Yeah, exactly right, Hadar. You described the situation very well that most physicians find themselves in. You're like in the middle of clinic or you're doing notes and a great idea comes to you and you get so excited about it and you come up with a way to sort of solve it or to bring a solution that could help patients. But then you realize, wait a minute, I don't really know where to start. I don't know the process. But imagine if we can find a way to help clinicians like that, to identify and define those unmet needs and problems they see every day and work collaboratively with research faculty to solve them. Imagine if we could harvest those great ideas and turn them into actual products and technologies that solve real-world problems for our patients. This will not only benefit our patients, but also all the stakeholders in biomedical innovation pathway, including clinicians, researchers, hospitals, investors, and even the pharma industry. So the Magic Wand Initiative is an academic initiative that was designed by clinicians for clinicians to actually help clinicians to get involved in such innovative process of problem solving. So our vision was to really use this as a framework to engage and empower clinicians in dermatology to identify and solve problems and become leaders in biomedical innovation.
Wow. Well, that sounds like the right medication for the problem. So tell us a little more, how does it actually works, right? Because this all sounds great, but we all know, I think, at least I know for a fact that everybody on this recording now have been part of some innovation. And we know it is not easy. It requires a lot of mental strength and durability of your will to really take a baby project all the way through even to just to conceptualize it into an idea, let alone into something on the market. So,
hey, Hadar, remember our mentor, and a little shout out to our mentor, Dr. Rivka Isroff, for the two of us. But remember what she used to say? Ideas are dime a dozen. Executing them is a lot more expensive than a dime.
I know. Yeah. She used to say, ideas, you got ideas. Who cares? You need to execute them. Right. So how does this work in detail? Like, tell us what happens. So I sit in clinic and I have this idea. Then what?
Correct. So look, I recognize that innovation driven by a physician is not a new concept, right? But just like you said, there's barriers that have made engagement and meaningful contributions very difficult for most clinicians. I mean, that comes from lack of education of knowing the process. We've actually done studies and shown that. And also it comes from not having access to tools and know-how to engage in the process and just kind of being intimidated and overwhelmed. So what we've done with the Magic Wand is, knowing this, we redesigned the entire sort of innovation pathway and developed a more clinician-focused pathway that reduces the barrier to entry. Okay, so the first 3 steps in this Magic Wand initiative pathway, which number 1 is to identify and define the problem. Number 2, to vet that problem with like your fellow clinicians within your department. And number 3 is to sort of brainstorm some strategy and solutions and come up with what we call spec sheet, which is like a list of all the criteria that a given solution should satisfy. All those 3 steps, they really don't cost that much. And they're really fun once you're able to bring the clinicians into one room and tell them, like, look, we want you to spend the next 2 months just writing down problems from your clinic, problems you come across, problems you feel passionate about, problems that, you think need better solutions. We don't want you to have a clue about how to solve it. Because, see, this is the key thing. Like, a lot of people think the only way to get engaged in this is if they have like a good idea for solution, but that is not the case. So we just tell them, just if you feel passionate about a problem, take out your Magic Wand. We actually gave them 3D printed Magic Wands to our clinicians.
That's awesome.
Yeah, it was really cool. It like made them feel empowered. We told them to carry this in their wide coat pocket, and every time they came across a problem that they felt passionate about solving, to just take out their Magic Wands and just write down the problem on a piece of paper.
This is brilliant.
Yeah.
Totally brilliant, because now you actually can just come and think of ideas, and you have someone else who's an executor figure out which ones are the most executable, or to go figure out what can be solved. What a brilliant way of approaching it.
Exactly. So, what we recognize is like really the edge and the power that our clinicians have is their access to the problems, the everyday practical clinical problems they come across, right? No one has the front row seats to Mother Nature's drama the way clinicians do. So we wanted to make them realize that and just bring problems. Like we told them, you don't have to have a clue about how to solve them. Just find one, write down the facts of the problem, and come and present the facts. No solutions. We specifically said we don't want solutions, because the minute someone brings a solution, it's like your mind is already narrowed and boxed towards that one angle. But when you just spend time understanding the problem, talking about the facts, you actually think more creatively and more outside of the box. So we told them to do that. 2 months later, Rox and I, who's my mentor, and actually this was his New Year's resolution to do this initiative, and he recruited me to help him. We organized a brainstorming session, which was department-wide. We made a list of all the problems our clinicians brought. And after clinic hours, we sat down in a conference room with over wine and cheese. We just said, let's just go through the list and let's just talk about the facts. Each person had 5 minutes to present their problem. And then we allowed the whole group to discuss, and get some input from some of the really experienced clinicians if they thought this was a good problem or not, or if they would reframe it. We really tried to focus on practical problems problems where we as clinicians had critical insight that others have overlooked. We didn't want to focus on problems like melanoma, right? I mean, that's such a big problem. Like, we're not going to solve that. But if there was something really specific, for example, irritation from minoxidil for hair loss, that's a practical problem. Or patients not being able to put on compression stockings. That's a practical engineering problem. You could definitely develop a team around that to solve it. So after, that night, honestly, our clinicians loved it. Like, they were so happy they didn't want to go home because we were just sitting there discussing problems. I can tell you that just from that one night, 50% of the problems they had brought was solved just from discussing with each other and like finding out different ways of dealing with certain problems. We came up with like a list of 30, and then, we honed that down to shorter list, about 10 or so. And what we did is those top 10 problems that were, tasty enough and practical enough, and there was a passionate clinician who wanted to lead, we said, go back and like get more detail about your problem, study it a little bit more in depth, and we'll organize a small brainstorming session to meet one-on-one with those clinicians to then start strategizing how we could like approach this in terms of solving it.
So I want to stop you here because I think there's so much to unpack here, but one thing that I kind of paid attention to was those 50 problems that seem to have been solved just by sharing the problem with other clinicians. Did I hear you say that correctly?
Yeah, 50% of the problems. So we
50%,
about 30 problems. So yeah, half of them were solved just from discussion.
That's amazing. So somebody said, hey, I can't do X, Y, and Z. It's a real problem for me. And somebody said, hey, I've been doing this for 20 years. Let me tell you how I do this. Exactly. And that kind of solved the problem. Right. Oh, that's such an easy thing to do in every group. I mean, you can be private group. And by the way, across specialty, that sounds so easy. But I think a lot of times we get into this kind of routine of practice and we forget or just feel embarrassed or think that we're the only ones who are having this problem where, as cliche as it may sound, it's everybody's problem. Okay. Thank you for clarifying this because I think that's just the communication that you facilitate with this magic wand seems to.
Well, Hadar, I have a question on this. There's two sides to this magic wand. You have the clinicians coming up with the problems. How do you decide? You've obviously got all these people talking about things. I love the fact that you're probably making new friends as part of this magic wand initiative. Maybe the magic wand is also friendship. But the other part of it I see is how do you decide which problems you're then going to go after?
Yeah. Very good question. So, what we did is like we allowed our whole community of clinicians, right, who were present there. And some of them might have not even brought a problem, or some of them might not have the time to pursue solving one, but they were engaged in helping us vet the list, and frame the problem in such a way that it just made sense. And we kind of tried to find the ones where like, as a group, we agreed that, this is truly a really good practical problem that I think, it's solvable enough. And of course, with Rox's experience and with the experience of a lot of our clinicians, we were able to efficiently and effectively do that. And we also looked for problems where like, as I said at the beginning, where we as clinicians have critical insight. I gave the example, for example, the compression stocking, that like you won't know as an industry or research person that guess what, even though if this work well when you do testing, in real life it doesn't work well because patients just can't put it on or they hate the feeling. You see, those are critical insights that only through interacting with patients and taking care of patients you get as a clinician. And by having that information, you could now like redesign, right, that device or product in a way that would be more usable and more helpful. And things like that, I think, are sort of what we call critical insight that we as clinicians have access to that not other people have. We also would look at, for example, how nasty is this problem? Are there any acceptable solutions? If something already had an existing solution, but it works 75% of the time, then maybe that's not such a critical problem to go after, right? But if there's a problem where there's literally no solution, but we feel like, we have deep understanding and way of attacking it, then it's worth sort of going after that one. So it really depends. I cannot give you like a straight answer. It's just you have to kind of first discuss, vet the list, and then just dive deeper into the problem and see if you could find an angle that you could work with.
I just have to ask this, can we put COVID variants on that list?
Yeah.
Problems?
Absolutely. Yeah, I guess so. Hey, I think our listeners are now ready for an example. Can you give us maybe a concrete example of one project that kind of grew out of it and where it is right now?
Give an example of a success project. Yeah, so we published a paper about this in Archives of Dermatology where I gave 3 examples, but I'll give you one. So Daniela Krasinski, Dr. Krasinski is a clinician in our department, and she is very passionate about cellulitis. She's done a lot of papers showing that misdiagnosis of cellulitis, especially in ED, is a major problem, right? A lot of times they call dermatology consults to rule out bilateral cellulitis. I mean, that's the number one reason dermatologists in hospitals get consulted for. And she had written a lot of papers showing that this costs healthcare industry a lot of money. Of course, patients sometimes get admitted even if they don't have cellulitis and get treated with antibiotics. So she brought the problem of finding a better objective measure of cellulitis as like her problem worth solving, right? So she thought if we could create a device where like people in ED or primary care could use it to rule out cellulitis, that would help. So we met with her, we brainstormed, we learned more about the problem. We made a specification sheet of what are the criteria that this solution must meet. And with that, we kind of came up with several strategies that she could pursue in parallel to try to tackle this problem. One of them was finding a way to, quickly check, like at point of care, whether there's a bacteria present with redness and lower extremity swelling. Another approach was to use some sort of thermography, some sort of imaging method to be able to measure the temperature and the flow, the redness in the lower extremity. With that, once we knew what she needed, what tools and know-how, we connected her with research faculty who possessed those skills, and they worked with her to tackle this problem. And I'm proud to say that, after a year or so, they actually developed a device that was able to measure the temperature and through an algorithm be able to sort of differentiate cellulitis from other cellulitis mimickers. And they published this paper in JID. Now, the second iteration of that device, they incorporated other more sort of objective measures of, blood flow. Is it venous blood or is it arterial blood? Temperature. So all those things like combined together created a prototype device that's now actually being licensed to do a human trial, right? To see if this can potentially be used.
That's amazing.
System. Yeah.
That's really great. As a personal note, I must say that I'm so proud that we're talking about compression and venous dermatitis here. I'm really, really happy about this. I couldn't be happier. Thank you so much for picking that example.
Let's give Hadar some time. He's going to get emotional here, Lilit. So.
I know. All right. So now I want to ask you a question because, one of the things that, I mentioned before, there's a lot to unpack. And I feel one of the things that we are acknowledging here as a problem is the way we are educating ourselves as a medical community, as people go through the processing chain of becoming a physician in the United States. And I feel that, and I always tell this to the students and residents, that you have to stay curious, that you can't lose that passion that you have in your first year of medical school. Remember that kind of, fidgety kind of feeling you have, that you're curious about science, you're curious about human beings, about wanting to solve some of these problems. Did you ever think of maybe how to incorporate this into the medical curriculum and how we train people to sort of shift towards innovative thinking throughout their training?
Yeah, of course. So that's a really good point, Hadar. And I could tell you that once people started hearing about our success with the Magic Wand initiative within our institution, we heard requests from other residents in dermatology from different institutions if they could start their own program. This is, of course, not medical school, this is residency level, but I think that's still a time and opportunity where we could teach this innovative curriculum to other clinicians, right? So what we did is at that time, Adam Roth, he was a physician and a resident at MGH and then joined our lab. Like we joined forces and we co-founded the Virtual Magic Wand program in collaboration with AID, which is Advancing Innovation in Dermatology. It's a nonprofit organization. They supported us to start this Virtual Magic Wand program, which was a 10-month virtual curriculum that was year-long. And we accepted clinicians, residents from across the country. I mean, we also allowed clinicians who had just finished residency to apply and join as well. And we accepted them and we taught them this whole Magic Wand process. We told them, to go and identify problems, bring it to our brainstorming session. We invited all these KOLs from across the US, people who were like past AAD presidents or expert clinicians to come and join those brainstorming sessions and help our virtual Magic Wand scholars sort of hone through their problem list and try to identify the one that was worth solving. We taught them how to define the problem in a way that was a solvable problem. We gave lectures and didactics on the entire innovation pathway. What are the important steps, taking into consideration the regulatory aspect of the device or product they're developing, what is IP, what is startup, and how do you go about to do that. So it was a really great program that we started in 2017. It was so well liked that we've run it every year, except the year when we had the pandemic. And this year we have our largest class ever, 22 scholars from across the US. And we even have full professors applying to be part of this program. In addition, because of the success of the Virtual Magic Wand program, I was approached by Leo Pharma to replicate and expand this program to Europe. And this year, I will be launching the European Virtual Magic Wand program to, again, engage, empower, and teach clinicians in Europe how to get involved in problem-based innovation. So I think there's a lot of thirst, there's a lot of interest, there's a lot of engagement that the clinicians want from medicine. Aside from taking care of patients, they want to be part of this process of actually thinking critically, using their creativity, their problem-solving skills to actually help patients. And I think, at one point going forward, I do want to take this to the medical school level as well, because I think once you teach someone this design thinking process and you give them the framework, they could use it anywhere. It doesn't have to be in clinic,
Right.
They can use it for every problem that they face.
No, absolutely. This is just spectacular.
Well, Hadar, I have one more question for her, actually. So, you're bringing all these clinicians together. By the way, this is music to our ears because every time we see problems in the clinic, if we do a lot of clinical research, we're able to at least somewhat act on it and go after certain problems. But who are those other stakeholders beyond the clinicians that you believe need to be present to make this sort of initiative possible? Because the clinicians may bring problems, but the problem solvers many times aren't clinicians, or maybe they are, but there's going to be an eclectic and integrative group to innovate.
Yes. So very good point, Roger. So the other major stakeholders obviously are the research scientists, right? So we have unintentionally separated passionate clinicians from research scientists to the detriment of everyone, right? Like big biotech is aimed at blockbuster new drug and devices, and it often skips over problems commonly faced by patients and doctors every day. And even in academic institutions, biomedical research is mainly done by excellent scientists and others who've never taken care of patients. Meanwhile, the physicians are increasingly taught to be more efficient and compliant at the expense of being creative problem solvers. So what this program does is tries to connect that gap, right? We connect passionate clinicians who understand and see the problems with the scientists who have the tools and know-how. And sometimes, scientists have amazing tools, but they have no idea as to where can this be applied or used in medical care to make a difference. And I think programs like this are able to connect the two, and in the process, allow physicians and scientists play their best role. Other stakeholders, of course, are hospitals, our industry. I mean, when clinicians succeed in solving problems, hospitals save money. Hospitals, when clinicians collaborate with scientists and make the research more patient-oriented and more high impact, hospitals still benefit because they get grant money. I have examples of that happening within our program. And at the end, no matter what product or technology is made, guess what? Hospitals or institutions are not going to commercialize it. The industry is. So the benefit also comes back to the industry because now they will have something to make and to bring to market, which they will benefit from. So I think when you do this right, everybody benefits, which is why I've been such a strong advocate of this. And I really think it's something that we haven't really optimized and used effectively to make a big difference, and we could do better.
Lilit, I think that what you're doing is very, very interesting. I mean, Hadar and I was an engineer before I went to medical school. And this is kind of like front of mind for us is how do you innovate? And I appreciate you bringing up the industry because in some cases, even with research, I find, and I want to hear your thoughts, I find bringing industry in earlier, even before the scientists get involved, sometimes really makes a lot of sense because they're willing to fund certain things or they already have access to certain commercializable assets that can then go out there and be immediately impactful if you are able to devise the right kind of a question or right kind of a tool. So how do you bring industry into this? Is it in the very beginning or is there a process in the Magic Wand Initiative?
Yeah, so I mean, I think it really depends, right? I mean, if the project is developed enough where you feel like, oh, of a product that you could use to solve your problem, then we approach industry. Like, for example, with the case of Dr. Krushinsky, one of the strategies we were looking at is there a way where we could sort of take a tiny little sample of skin and within an hour do some sort of PCR or some sort of diagnostic test that will tell us, is there bacteria there or not, right? So at that time, there was a biotech company, T2 Biosciences, I believe that's what they were called. And they were actually trying to develop a product that could detect bacteria at such low levels. Like even if there was one single bacteria, they would be able to pick it up, right? So we connected Dr. Krushinsky with them to have early talks if that's something that they would want to collaborate on, right? That's one example. Sometimes it's too early because you want to do a little bit of proof of concept and maybe protect the idea with intellectual property, before you go and tell industry your thoughts and ideas. But I think, industry is our friend. And unfortunately, a lot of clinicians, including myself, before I started working in Rox's lab, we always viewed industry as the dark side, true academicians don't stay away from industry, they're just out to get your ideas and your products. But I think now I reframe and I look at industry as our friend, right? I mean, yeah, we have different sort of goals at times or priorities, but we do also have common goals. And our common goal is really to help the patient. And if we focus on those common goals and work collaboratively, I think, we could make big gains in creating new products to help patients.
That was so well put. Well, Dr. Garibyan, this has been a tour de force of the Magic Wand Initiative. And I think what I wanted to just briefly ask you, if someone listening to this wants to register to your program, where do they go?
Yeah. So we have a website now. It's www.magic1initiative.org, where the application process starts around the AAD. It will start in September for the European program. We're also piloting this out in some institutions, like I'm helping pilot this out in UMass Department of Dermatology and Vanderbilt Department of Dermatology. So there's multiple ways to get involved, and we're also have social media presence, and I encourage people to find us.
All right, look up the magic wand. And I want to tell you that, this is such a great initiative, not just to help patients, but also to help doctors. And I alluded to it a little bit earlier because we are all talking about physician burnout. And I feel that one of the major reasons for burnout is because you lose that passion I described earlier. And so instead of us thinking, oh, how can we invest in making fun for our faculty and let doctors innovate, let them do what they love to do. They'll be much happier. You'll reduce burnout just like that. So there you go. That's your next project. Measure the burnout level in your graduates.
You are spot on. We're actually actively doing those studies because we've gotten feedback from the faculty involved in these programs that they actually feel much happier. They feel more engaged. They're more likely to recommend their job to others. And when people work on something that they feel passionate about, they're using their creativity, they are affecting change around their environment, it almost is an antidote to that learned helplessness.
That's wonderful. I'm so happy to hear that because that was my hypothesis and I'm glad it's going to be true. So thank you so much for sharing with us this initiative. I'm sure all our listeners are now eagerly Googling, looking up the Magic Wand Initiative, and you may get bombarded with applications. Thank you so much for affecting change in your environment just with this idea. I'm going to go and devise my own magic wand right now. Thank you for joining us.
My pleasure. Thank you for having me.
And to think this was the stuff of Photoshop and now it's real life. Thanks, Lilit.
Oh, yeah. My pleasure.
Thank you for tuning in to today's episode with Dr. Raja and Dr. Hadar. This podcast is brought to you by LearnSkin, leaders in integrative dermatology education. Visit learnskin.com/podcast to explore our many programs or subscribe to the podcast today and never miss an episode. Hey, have a great day and stay curious.